Welcome back to another CHT Prep Practice question session. This is going to be for the month of March 2024. The way this works, if you haven't been here before, is I'm going to go through 15 practice questions for CHT Prep. Go ahead and grab a pen and pencil or your computer or something to write with so that you can record your answers as we go in real time to the questions. Feel free to pause the video as many times as you need if you need a little bit more time. After we get through all 15 questions, we're going to go ahead and go back through the questions, go through the answers, and I'm actually going to give you guys a rationale this month, which is something that somebody on my Instagram requested. So thank you for that suggestion. Let me know if you guys like that format. I'm still playing with this, to be honest, and figuring out what is going to be most helpful for you. So please comment below if you have any suggestions or ideas or anything that would make this more useful or more helpful for you. Let's go ahead and get into it, and let's get ready to take the CHT test. Woo woo! Question 1. Heberden's nodes are calcific spurs at the A, DIP joint, B, PIP joint, C, MCP joint, or D, thumb MCP joint. Question 2. The Strickland hinged wrist orthosis would be used in which of the following flexor tendon rehabilitation protocols? A, MAMTT, B, modified Duran, C, Indiana early motion, D, Kleinert. Question 3. You are evaluating a 29-year-old athlete with a primary complaint of ulnar-sided wrist pain after falling on his outstretched hand during his soccer game 1 week ago. X-rays were negative for fracture. Provocative testing indicates a TFCC ligament injury with no signs of instability at the distal radio-ulnar joint. Which of the following would be the most appropriate to incorporate in the treatment plan at this time? A, fabricated long-arm Munster orthosis and review adaptive techniques for performing ADL. B, instruct the athlete on pain management techniques, including using ice and taping with kinesio tape for support. C, initiate active range of motion to the wrist and forearm 10 times every hour. Fabricated wrist cock-up orthosis to wear between exercises. D, instruct the patient on proprioceptive exercises for the wrist and instruct them on how to modify activities to protect the healing structures. Question 4. A crossover of nerve fibers from the anterior interosseous nerve to the ulnar nerve in the forearm is known as A, Martin-Gruber anastomosis, B, Marinacci anastomosis, C, Rich-Kanu anastomosis, or D, Berrettini anastomosis. Question 5. Which of the following tests can be used to diagnose central slip injuries? A, Wartenberg's sign, B, Cozen's test, C, Elson's test, D, Jean's sign. Question 6. Which of the following is not true regarding treatment of Zone 3 extensor tendon injuries after surgical repair following a static immobilization protocol? A, the PIP joint should be immobilized between 3 to 6 weeks after repair. B, if the lateral bands were not injured, the DIP joint may be left free from orthosis. C, PIP flexion should be limited to 45 degrees initially after the immobilization period. D, after the immobilization period, extensor lag at the PIP joint is carefully monitored. Question 7. A patient with a brachial plexus root injury complains of sensory disturbances to the tip of the middle finger. Motor testing reveals weakness of elbow extension and wrist flexion. What root is affected? A, C5, B, C7, C, C8, D, T1. Question 8. Which of the following is not a site of compression in thoracic outlet syndrome? A, first rib elevation, B, pectoralis minor, C, upper trapezius, D, scaling muscles. Question 9. The measure of the proportion of true negatives that are correctly identified is known as A, sensitivity, B, specificity, C, type 2 error, D, type 1 error. Question 10. When lifting the arm between 0 to 60 degrees of shoulder flexion, which of the following scapular force couple muscles provide support? A, serratus anterior and lower trapezius. B, deltoid and infraspinatus. C, upper trapezius and serratus anterior. D, infraspinatus and supraspinatus. Question 11. A patient presents with proximal volar forearm pain and weakness of the thumb IP and index DIP joints. The patient denies sensory disturbances. Based on this information, where would be likely a site of median nerve compression? A, ligament of Struthers. B, lacertus fibrosus. C, transverse carpal ligament. D, Ganser muscle. Question 12. Kienbach syndrome is avascular necrosis of the A, scaphoid, B, pisiform, C, triquetrum, D, lunate. Question 13. Which of the following is true regarding the proximal interphalangeal joints of the hand? A, collateral ligaments are taut in extension. B, prolonged immobilization should be in flexion. C, check rein ligaments of the volar plate shorten in flexion. D, PIP joints are ellipsoid joints. Question 14. You guys are almost there. Keep going. What best describes the assessment for the T1 myotome? A, resisted elbow flexion. B, resisted wrist flexion. C, resisted thumb extension. D, resisted finger abduction. Question 15. A patient is able to detect 3.61 during Semmes-Weinstein monofilament testing. How is this result interpreted? A, normal. B, diminished protective sensation. C, loss of protective sensation. D, diminished light touch. All right, you did it. Congratulations. Nice job taking those 15 quiz questions or practice questions for the CHT. Go ahead and pause the video if you need a little bit more time. Feel free to go back through the questions one more time and double check your answers. Make sure that you have your final answer committed to so that you can truly test your knowledge. Let's go ahead and go back through each of the questions and go through the rationale and the correct answer. Let's do it. Okay, so for question 1, the correct answer is A, the DIP joint. So the Heberden's nodes are typically the first sign of OA in the hands. At the PIP joint, they are the Bouchard's nodes. Changes at the MCP joint are often more a sign of RA, so that's kind of where your thinking process should be on question 1. So for question 2, the answer is C, the Indiana Early Motion Flexor Tendon Protocol. It is good to look back at these protocols and familiarize yourself with the orthoses used in each protocol. Indiana Early Motion uses a dorsal blocking splint with a hinge at the wrist that they use hourly. And then in between exercises, you're going to use a dorsal blocking splint. So that's that Strickland hinged wrist orthosis. MAMTT is actually not a protocol, but a concept, and uses the short arc motion protocol, which has a dorsal blocking splint with elastic traction. The modified Duran uses a dorsal blocking orthosis, and then Kleinart uses a dorsal blocking splint with rubber band traction. Question 3, the answer is A. The rationale here is that this is an acute injury 1 week ago. Conservative treatment with no instability would support splinting in a long arm orthosis with the elbow at 90 and forearm neutral. So that's why the Munster orthosis is probably a good one to use to practice symptom reduction. After that initial 6 weeks, as the pain is starting to resolve, you can start some active range of motion and transfer to more of a wrist cock-up splint. And then I do think proprioception is probably going to be a pretty important component of rehab after that initial immobilization or that rest period. Question 4, the answer is A. Martin-Gruber anastomosis. For the Marinacci, that's the reverse Martin-Gruber, which is a rare interneural connection or communication between the ulnar nerve and median nerve in the distal forearm. Rich-Canu is a connection between ulnar and median motor nerve in the palm. And then Berrettini is a connection between the common digital nerves of the ulnar and median nerves. Question 5, the answer should be C. Wartenberg's sign is an ulnar motor sign. Cosen's is for testing or assessing lateral epicondylitis, and Jean's sign is an ulnar nerve motor sign. For question 6, the answer is C. In zone 3 tendon injuries, the most common, it's going to depend totally on the protocol, but most commonly I have seen that after that initial immobilization period, you typically will start with about 30 degrees of active PAP flexion and then gradually increasing that by about 10 degrees a week. This, I'm happy to hear other protocols too. That's just the ones that I see the most, or kind of what I've seen the most in established extensor tendon protocols. So let me know if you've seen anything other than that. Question 7, the correct answer is B, C7. This is a match the dermatomes and myotomes type question. So when we're thinking dermatomes, C5 is the lateral upper arm, C8 is the small finger, and then T1 is the medial forearm and upper arm. That's where they're going to feel those sensory disturbances. Question 8, the correct answer is C, upper trapezius. If you were not sure of this, I don't have a great rationale. It's just kind of a fact. So I would just go back and study the compression sites of the nerve conditions, and in particular thoracic outlet. Question 9, everybody's favorite, statistics. The answer here is B, the specificity. So the rationale here is that sensitivity is a test's ability to designate an individual with disease as positive. A type 1 error, a false positive, occurs if the investigator rejects a null hypothesis that is actually true. A type 2 error is a false negative, occurs if the investigator fails to reject a null hypothesis that is actually false. Question 10 is all about shoulder biomechanics. Answer is C, upper trapezius and serratus anterior. At the 0 to 60 degrees, the glenohumeral joint stabilizers are deltoid and supraspinatus. At 120 to 180 degrees, the lower trapezius will also kick in with the upper trap and serratus. So between that 0 to 60, it's going to be upper trap and serratus anterior. Question 11, the correct answer is D, Ganser muscle. The Ganser muscle is an accessory portion of the FPL or the FDP. It's an anatomical variation that can occur, and it can contribute to median nerve and anterior interosseous nerve compression, loss of FPL and FDP to the index, which is like a weak pinch. No sensory complaints here, so this is likely an anterior interosseous compression. At lacertus fibrosis, they'll have sensory symptoms. Same with the transverse carpal ligament, plus they typically wouldn't have symptoms in the forearm if the compression is at the transverse carpal ligament. And then compression at the ligament of Struthers usually has pain in the forearm, which is accentuated during wrist extension. So correct for question 12 is D, the lunate. That is related with Kienbach syndrome. That's that avascular necrosis. Avascular necrosis of the scaphoid is actually called Preiser's syndrome. Question 13, the answer is C. The rationale here is that the collateral ligaments are taut in both flexion and extension at the PAP joint. Prolonged immobilization at the PAP should be in extension, not typically flexion. And then the PAP joints are synovial hinge joints, not ellipsoid. 14 is another myotome question. Correct answer here is D, resisted finger abduction. So when you're thinking through the myotomes, remember that C5 is shoulder abduction, C6 elbow flexion and wrist extension, C7 is elbow extension, C8 is thumb extension, and then T1 is resisted finger abduction. For question 15, woohoo, you made it. The answer is D. Diminished light touch is that response that correlates with 3.61 with Semmes-Weinstein testing. If you did not get this question correct, might be good to go back and check your Semmes-Weinstein monofilament values and what they what the results mean, what the interpretation of the results mean. Okay, congratulations. Again, you made it through all that nitty-gritty stuff. I know that it's not that fun taking practice test questions, but the more things that you're exposed to, I think that the better you'll do on the exam. And it's nice to be able to practice test taking skills, answering questions, giving yourself a time limit. I hope you guys enjoyed this. Let me know. I'm still trying to work out like what the best format is and what you like the best, what is most helpful for you. So, comment below if you have any suggestions. Like, do you like that I'm reading the questions off? Would you rather have like kind of some background, really chill, lo-fi vibe music playing, and you can just go through the questions and I'll give you, a few seconds to kind of look at each one, and then go through the rationale. Do you like the rationale? Do you not? Just give me any suggestions. What would you like to see with the formatting of this series that I'm hoping is very helpful for you and that I want to continue throughout the rest of the year? Thank you guys so much for watching. If you have not subscribed to Forward Therapy, it really helps me out. So I appreciate you if you can do that. Give a thumbs up if you enjoyed this video, and comment below if you have any suggestions for future content or if you want to see anything different with the CHT prep. And I hope you have a wonderful rest of your day. Thank you guys so much for watching. Bye.